Today, I'm going to talk from a clinical perspective about the problem of obesity. We'll focus on data approaches, data-driven approaches to the problem, and keep it system-oriented to some degree. But I'm talking today, a little shift of gears from the earlier speakers, about primary care settings where there's more of a bifocal approach to the problem. Next slide. It's not just the social policy and other community milieus. It is what happens when an individual person walks into an office and has got obesity. Next slide. No conflicts. What happens? Is there something that can happen that will help that individual person deal with the problem of obesity? Now, I recognize, want to truly emphasize the fact that prevention of obesity is job number 1, 2, 3, 4, and 5. And all the approaches that the Roundtable has put forward in their model are appropriate and make important contributions to the prevention side. But there are people that are obese and significantly obese. And the question is, what can be done to help them? Now, I would also mention that in the primary care setting and other medical settings, the care of management, clinical management, and care of people that have problems with overweight or obesity is far from optimal. However, this isn't only a problem with care for obesity, it extends to care for diabetes, hypertension, cholesterol, heart disease, you name it, asthma, depression. There's many deficits in chronic disease care across the healthcare system, and therefore many opportunities for improvement. Today, I'm going to focus on something my team has been working on for about 15 years, which is primary care-based clinical decision support systems as a way to improve chronic disease care, including obesity care. But I want to recognize also that the scope of this talk focuses on that. There are many other strategies that can also improve quality of care, including opinion leader interventions, audit and feedback interventions, and simulated learning, gamification, and incentives, among others. Next slide. This is an important slide. The columns show different levels of overweight or obesity expressed as body mass index, where the putative norm is 18.5 to 25 kilograms per meter squared, and the medical definition of obesity is a BMI over 30. For anybody that has issues related to weight, lifestyle interventions and lifestyle change are clearly indicated and important, and this is across the board for all such patients. However, the impact of lifestyle on weight, lifestyle change on weight, is highly variable, as are all these interventions are highly variable at the individual level. But on average, the amount of weight you might lose might be 5% lower a year later, if you're lucky. There are also a number now, 4 FDA-approved medications for longer-term treatment of obesity. They each have their own advantages and mechanisms and side effects. Several of those medications can give you a 10 to 15% weight loss at 1 year out. The proportion of people with higher levels of obesity that are in fact on these medicines is very, very small. It's probably well less than 5% of the people that have these levels of obesity are taking these medicines or have tried them at all. But they do have a bigger impact than lifestyle, and the impact can be synergistic with lifestyle. If you use both, you'll get a synergistic impact. The third level of treatment is metabolic bariatric surgery, often called bariatric surgery. There's a couple different procedures. This is quite effective in terms of managing people with elevated BMIs, serious levels of obesity from the medical point of view. And the average weight loss here is about 100 pounds. And the amount of that weight loss that's retained 2, 3, 4 years later is more than half of it. But again, this is used very infrequently. Less than 3% of people who have BMIs over 35 consider bariatric surgery each year. Next slide. But I'm going to focus right now on bariatric surgery for 2 more slides. The effectiveness of bariatric surgery, and this is now as in people in type 2 diabetes, which is a grant I'm going to talk about, focuses on adults with type 2 diabetes and BMIs 35 and up who are eligible and considered potentially beneficial for bariatric surgery. The impact of it on coronary artery disease, which means heart attacks, basically cuts in half the risk of a heart attack in these people with diabetes over a 7-year period after the operation. Next slide. There are very few things, by the way, that cut the risk of a heart attack in half. Even smoking cessation, probably not quite that effective. And then there's also an impact on life expectancy or mortality. And you can see here that the percentage of people that died is what's being graphed here. And the percentage of people that die over a 12-year period who have surgery is quite a lot lower than the percentage of people that died among those similar patients that didn't have surgery. This is cohort study data, 12-year follow-up, and there's always the possibility of residual confounding. But these analyses have used very sophisticated analytic, statistical techniques to try to reduce the likelihood of that kind of bias. Next slide. So we see that on average, those 2 slides show that on average, your heart attack risk goes down by half. Your mortality risk goes down by nearly half. But there's huge variation at the patient level, right? And this is true of all clinical interventions, including those for obesity, including lifestyle medications and surgery. From person to person, you cannot predict what the impact of surgery or medications or lifestyle will be. But analytic studies that I've been involved in with large teams of people and large databases, led largely by David Arterburn at Kaiser in Seattle, Kaiser Washington, Kaiser Permanente, Washington. We've looked at hundreds of thousands of people with and without diabetes, and looked at what are the things that predict the benefit of bariatric surgery. It's heavily related to your age. Younger is better. Your sex, female, is better. Your baseline BMI, closer to 35. All these people are over 35, but the closer you are to 35, the better. Your baseline, pre-surgical glucose control, if it's better, the outcomes are better. Whether or not you've had diabetes for a long time and have to use insulin, and the people that have had it for a long time do worse, and other comorbidities like heart disease, et cetera, that are already established prior to surgery. And the magnitude of individual level variation in terms of the benefits from surgery is gigantic. So that in the green, you can see that if you have like a 40-year female with recently diagnosed diabetes, not on insulin, a BMI of about 40, that person on average may gain up to 6 years of quality adjusted life year. There's not much that adds 6 years of quality adjusted life years to your life, although Nico would say that if you have a perfectly good lifestyle, you probably could gain that and more. Although only, Nico, 6% of the people in the country have that lifestyle profile. Other patients have no benefit at all. And surgery is very rarely done in people that are 70 or over. The older you are, the less benefit. So an older person who's a male with longstanding diabetes may gain no quality, and some of those patients on average may lose a few months of quality adjusted life. Next slide. So we've trying to figure out how do you inform patients and primary care clinicians and other clinicians, educators, et cetera, of the fact that these benefits can be substantive for some people and not so substantive or really negligible for surgery and others. And to a lesser degree, that's also true of medications. There's some people respond better to medications than other people. So the strategy we've adopted that I want to talk about right now is using data-driven clinical decision support systems in clinical settings, such as primary care settings, to try to do a couple of things. First of all, to process the data in real time, clinical data that's in the EMR, and when available, patient-reported data about lifestyle. Use web-based algorithms to translate that information in order to identify appropriate weight loss options for a given patient. This is a patient level now. What are the things that for patients like this patient, not for Joe Smith, but for 100 patients like Joe Smith or 1,000 patients like Joe Smith, what might you expect from medications, from surgery, et cetera? Identify which of these weight loss options are appropriate. If Joe Smith is over 70, surgery's off the table. If Joe Smith has a contraindication to one of the weight loss medicines, kidney stones or something like that, or gastric emptying problems, that certain drugs are off the table. So you want to identify options that are potentially beneficial for a given patient. And then you need to communicate that information both to the patient and to the clinician to promote a shared decision-making process. Now, I would emphasize we've done this kind of clinical decision support for about 10 years, and we haven't scaled up to about 3 million patients right now. It's in about 12 medical groups in 10 states that provide care for about 3 million patients. And I'll show you in a minute, we haven't done a lot with obesity thus far, but we're planning to focus on that next. But the system is up and running for blood pressure, cholesterol, smoking, glucose, and it works. So, in randomized trials where we randomize clinics and give some of the clinics the decision support and others no decision support, we've pretty consistently seen benefits on the care of the patients in the clinics that go to the ones that are intervention clinics versus usual care. In this particular grant, when we try to develop further the obesity decision support, the things we'll be looking at are whether the intervention has an impact on weight trajectories, on medication starts, on surgical referrals, not surgical occurrences, but surgical referrals for evaluation, and on patient-reported shared decision-making. Next slide. Key thing is, what do patients want to know? I appreciate the comments earlier today on communication. It's very tricky, particularly around obesity. But we know from other studies and from our own clinical experience that patients want to know how much weight will they lose, for how long. This applies to everything, lifestyle, medication, surgery. They want to know, is my diabetes going to go away? Will this medicine take away my diabetes? Will the surgery make my diabetes go away? And if so, for how long? I would note that among people with type 2 diabetes that have bariatric surgery, 80% of the people, the diabetes goes away. 2 years later, the diabetes is gone. And that happens usually soon after surgery. The diabetes abates in about 80% of patients. And 5 years later, 5 to 7 years later, half of them, the diabetes has come back. And half of them still don't have their diabetes. So for a substantive proportion of patients, bariatric surgery could be viewed as a cure for type 2 diabetes, at least for a period of time of 5 to 7 or 10 years or more for some patients. So patients want to know, is my diabetes going to go away and for how long? They want to know, can they stop their medicines? Can they get off some of their medicines? And the answer to that question is yes. If you have surgery, you can often stop blood pressure medicines, cholesterol medicines, and glucose medicines because the surgery benefits not only heart attacks, strokes, and life expectancy and weight, and diabetes remission, but also reduces blood pressure and cholesterol. Important consideration, what are the risks of surgery or medications? There used to be 1 in 200 people with surgery died. That was 15 years ago, bariatric surgery. Now it's about 1 in 1,000. And then insurance coverage for surgery is spotty, not always covered. That's a very important issue because the costs are about $20,000. People also want to know, is it going to lead to subsequent surgery to remove excess skin, which is sometimes the case? And what's the impact on quality of life? And the short-term impact of surgery is often positive. Long-term, there's no benefit, no loss. Next slide. How do we present information to patients and clinicians that's accurate, concise, and understandable? And there are a couple of issues here that are similar in some ways to the schools that Dr. Donnelly described a few minutes ago. Clinicians are in a hurry. They feel overwhelmed, just like teachers. Furthermore, they're unaware, generally very unaware of the patient-specific benefits and risks of surgery or medications. The diabetes guidelines right now suggest that all patients with diabetes who have certain levels of obesity consider bariatric surgery, and there's nothing in the guidelines to direct attention to the patients who would have gigantic benefits versus those that would have marginal or no benefits. And for a clinician to try to estimate that on the run in the context of a visit with no decision support is asking a lot. There are a subgroup of non-surgical clinicians called bariatricians who could probably do this pretty accurately. And they're in weight loss centers, so they're not seeing the primary care patients as a general rule. And then the other thing is clinicians have a fatalistic view about obesity management, unfortunately, on average, and are thinking, nothing's really going to work. Why even bother? And are often unaware that there are medications now that can lead to 15% weight loss, and the benefits of metabolic bariatric surgery can be substantive for some people. And that if clinicians frame their thinking about these treatments as treatments for diabetes rather than treatments for obesity, I think we would make more inroads with clinicians and how they think about it. And this would be a point I'd welcome discussion on later on. So communicating stuff to clinicians is important and challenging, but it's even more challenging to communicate it to patients due to issues related to numeracy and health literacy, personal and cultural meanings of eating, weight, and treatments for obesity, patient resistance, the idea of taking more medicines, and certainly of having surgery. A lot of patients run out of the room screaming if you mention the possibility of surgery for almost anything. And then there's the issue that obesity and overweight have are such emotionally loaded issues, not only for patients, but also for clinicians. Next slide. This is our first attempt to present clinical decision support information to patients at the point of clinical encounters. And we adopted this approach where we try to identify with symbols what are the things a patient could do that would be the most beneficial. And for this patient, who has a 10-year risk of a heart attack or stroke of 33% up in the right-hand corner, attention to cholesterol and smoking would be the biggest benefit indicated by the yellow marks. Glucose control would be of some benefit, and weight would be of some benefit. Now, how did we estimate the benefits of weight management? In this study, if a person has a BMI that's, say, 40, what do you estimate for the benefit of a weight loss? And we thought here, we took the estimated weight you could lose from lifestyle stuff, which might be 20 pounds. And we estimated the benefit based on a 20-pound weight loss, which is achievable by lifestyle. There's bigger weight losses achievable by medications or surgery, and those are not presented in this format. Next slide. Then we prioritize the things, and because we're only prioritizing a 20-pound weight loss, the weight loss benefit comes out pretty low on the list. In this example, it's the fifth thing down behind tobacco, cholesterol, blood pressure, and glucose control. This person would have some benefit from weight if they could lose 20 pounds. If they had bariatric surgery and could lose 100 pounds, weight management would probably be at the top of the list in terms of potential benefit, or at least second behind tobacco. I want to make this point that decision support that focuses only on obesity is probably destined to fail in primary care settings, because at the average adult primary care encounter, there are at least 4 clinical issues are dealt with, 4 to 5 on average. Decision support that is disease specific, for example, blood pressure, weight, depression, is going to be used very intermittently, if at all, in primary care settings, because there are so many issues to deal with. We've adopted the approach, and it's proven to be quite effective, that you give something like this. The decision support addresses multiple clinical domains, including blood pressure, lipids, smoking, weight, depression, kidney disease, etc., and you prioritize. So if you're going to address multiple clinical domains, you have to prioritize or you'll get no one's attention. So this is an effort to prioritize the things with the most black marks are the highest priority, and down at the bottom are things that need no attention. This is a patient view. Next slide. We also provide information to the clinician as well as the patient. The patient gets it in printed form right before the visit. The clinician gets it also in printed form and can view it on the screen. And as you can see, this has the same priorities if it's the same patient, but provides more information about lab tests and specific medication or treatment options, surgical or lifestyle treatment options. Now, I should say that these decision support systems that have been effective have also been used frequently. We're able to get decision support use rates of 70 to 80% at targeted visits. We only target about 20% of adult visits for this kind of decision support, which is largely related to heart disease, diabetes, and obesity. But when we target a visit, we're getting 70 to 80% use rates of the decision support, which is extraordinarily good. There's been some studies from Belgium and Australia recently where the use rates were less than 5%. Next slide. So there are several things to think about with respect to clinical decision support for management of overweight and obesity. First of all, it's important to direct the decision support both to the patients and to the providers, and to promote shared decision making. There's no effort to coerce either the clinician or the patient to do anything. It's more to inform them both to have a discussion about treatment options, a discussion that's based on the potential benefit of different treatment options. Second thing is decision support has significant impacts on care as a solo intervention, but its impact, I think, would be magnified if we're combined with other care improvement interventions, such as active outreach to patients, its registry-based case management, simulated learning for clinicians or patients, gamification, and incentives are all things that could interact with decision support in a positive way. Some of that work has been done, but a lot more needs to be done. And then we think that the estimation of the benefits and risks of different weight management strategies, lifestyle and meds and surgery, if those are appropriate to consider for a patient, would be an advance over what we're doing now. And then finally, we think that framing the discussion of obesity for diabetes patients as more of a treatment for diabetes would avoid some of the obstacles to getting people to act if it's framed as treatment for obesity. That, I suppose, raises some ethical questions. My father's doctor tried to get him on depression medicine for years, and my father wouldn't do it. Then when the doctor said, well, Joe, this pill's going to help you with your sleep, then my father was like, give me that pill. And it was a depression pill, right? So there are some issues there, but it's something to think about. Next slide. And then there's many challenges that are yet to be addressed. Both clinicians and patients underestimate the effectiveness and safety of both medications and surgery for weight management. And that's something that, if it were addressed, would help the patients that are out there now with obesity problems, would give them more treatment options. It's not going to prevent obesity, which is priority 1, 2, 3, 4, 5, but for the 2/3 of Americans that have got an existing overweight or obesity problem, it might help them manage their problem and give them some medical benefit. Now, whether the patient wants to engage in that, totally up to the patient. Not meant to be coercive. And then the challenge is how to communicate. Second one is how do you communicate these personalized estimates of benefit and risks, taking into account numeracy, literacy, cultural factors, and other things that could create a gap between the message you're trying to send and the message a patient especially is receiving. And then how do you tailor these communications, as I said, very important challenge. And then the last thing you want to do is worsen issues related to health equity. So will decision support improve health equity? We have signals in some of our studies that it does improve health equity, and that the algorithms will estimate benefits regardless of whether it's a man or a woman. They'll estimate the benefits as best we can with existing data. And the same applies to race and ethnicity to the degree that the prediction equations don't discriminate against people of certain groups, then the advice is an even playing field. The algorithms don't think, oh, it's not worth talking about this patient because they're, 65 years old and only finished high school. The algorithm is going to say, this is a patient who has a potential benefit. Here's the estimated benefit. So, there's a potential, we've seen signals that the use rates are as sometimes higher in women and sometimes higher in some racial subgroups when we use this decision support than they are in whites. So that needs confirmation, but it's a promising signal. I'm going to stop and we'll see if there's any time for questions. Thank you very much.